Welcome back, Titans. Today we are doing lactated ringers in our pharmacology section because we are choosing an IV solution to administer to our patient. Now, why would we choose lactated ringers versus, say, a 0.9% sodium chloride? We're going to get into that. But first, anytime we know that we are going to deliver a IV fluid to our patient, we have to know the categories: isotonic, hypotonic, and hypertonic. Now, lactated ringers and sodium chloride are in the isotonic class. Lactated Ringers is an isotonic crystalloid solution with a pH of about 6.5. So talking about our isotonic solutions, we know that it has the same concentration of sodium as does the cell. In this case, water does not shift or change in the cell. That's going to be our two examples. But why pick lactated ringers over our sodium chloride? When is it indicated? We can use lactated ringers for hypoperfusion, severe blood loss, burns, because we know there's going to be a water shift in our sepsis patients, but there's also some things that we need to be cautious for. So looking at lactated ringers, what are the contents? Remember, we're always going to do our cross checks and our administration checks and all that fun stuff before we do any sort of intervention or medication administration. Because lactated ringers has electrolytes in it, though they're just electrolytes, there are some cases in which we are not going to use this. So what is LR made of? We have sodium, chloride, potassium, calcium, and lactate in the form of sodium lactate, all with a water base. We happen to have a 1,000 ml bag here. So this is going to be great for our patients with a significant blood loss. Because it contains lactate, like the name says, we know that it's going to metabolize in the liver and form bicarb, which we know is the principal buffer on the body, and it's going to help us fight that acidosis and significant blood loss. But there are some issues with some of the electrolytes, and what do we need to look out for? So it's going to be contraindicated in our heart and renal failure patients. We know that because it contains potassium, we want to avoid this in our crush injury patients. Calcium can be an issue, especially when you're having a patient that's receiving a blood transfusion. So when somebody receives a blood transfusion, there's anticoagulants added in so it won't clot. The problem with this is calcium binds to those anticoagulants and you run the risks of giving clot. So it's going to be contraindicated. And then obviously the lactate, our patients with our liver problems can't metabolize the lactate. So we are going to avoid that situation as well. Nancy Caroline also says that it is contraindicated if we are using mannitol, solumedrol, nitroglycerin, norepi or Levophed, propranolol, and also procanamide. So what is the dose? The dose is going to be 20 mLs per key for hypoperfusion, IV or IO, over 15 minutes, and repeat as needed until our patient is able to perfuse appropriately. So hope this helps. Quick overview of LR. Make sure you're checking which IV solution is best for your patient, and I'll see you on the next one.